Welcome everyone to our special holiday edition of Mayo Clinic Q&A. We're recording this podcast on December the 21st, 2020, and I'm your host, Dr. Helena Gazelka. Well, in the last week, the news has been filled of reports and photographs of healthcare workers receiving the first COVID-19 vaccine. More vaccine should be available this week as another vaccine has been approved for emergency use authorization in the United States. We're excited to hear the updates about this today, so let's jump right into it with our favorite co-host and guest, Dr. Greg Poland, infectious disease and vaccine and virology expert at Mayo Clinic, who's here to tell us what's going on in the world of COVID vaccines.
Merry Christmas to you and to everybody who watches.
Yes, Merry Christmas, Happy Hanukkah, Happy Holidays. Good to see you, Greg. So wonderful to have you here today.
Beautiful Christmas tree you have.
Well, thank you very much. Yes, I'm broadcasting from home today because I'm off this week. So it's nice to be here with everyone. All right, Greg, let's jump right into it. We have a Pfizer vaccine, which has begun to be distributed, and individuals in healthcare in particular have been receiving it. And now Moderna's vaccine has been approved for emergency use authorization. Will you tell us again, what is EUA and what does this mean for us?
Yeah, so it's a very good question because EUA is different than a licensed product. EUA is a designation that says, given the data we have, we believe that the known benefits outweigh the known risks. That is different than a licensed vaccine that says the known benefits outweigh any known risks. So a subtle difference, but a meaningful difference. And what that means is that high-risk individuals will get the vaccine, as you pointed out. Healthcare providers around the US have started their immunization series, but more and more data will be accumulated under this EUA so that we can get to the point of a fully licensed vaccine.
Greg, here in Rochester, Minnesota, we have about 39,000 healthcare workers waiting to be vaccinated at Mayo Clinic. And I'm curious, does the fact that the Moderna vaccine was approved for EUA mean that we will have more vaccine available, or are those vaccines going to different populations?
No, it absolutely will mean more availability of vaccine. Moderna has about 100 million doses. They expect to deliver 20 million, as much as we have of Pfizer in the US by the end of this month. And then that next 80 million rolled out over January and February. So particularly when we get into January and February, I think we're going to see, unless something unexpected happens, we're going to see a lot of vaccines starting to become available.
So this is great news for our listeners as well, because as soon as healthcare workers and other essential workers obviously are vaccinated, we can start moving to the...
Absolutely. You know, the CDC Advisory Committee met this past Saturday and Sunday, and their recommendation after, the frontline healthcare workers is that essential workers and people over the age of 75 are the next wave. So that'll start happening, and we'll just kind of march our way down by risk till the point that everybody that wants one will be able to get one.
Well, it's wonderful that we're in a situation to begin considering that now and how to navigate that.
It makes Christmas all the more meaningful.
It certainly does. What a Christmas present.
Yeah.
Say, Greg, there's a third vaccine that is coming up close, AstraZeneca. Can you tell us about how that process is going and a little bit about the distinction with that vaccine and where it will be headed?
Yeah, there's still some work to do with the AstraZeneca vaccine. Now, this is an adenovirus vaccine. The Pfizer and Moderna vaccines are mRNA vaccines. The difference is this: with mRNA, we give the genetic blueprint, gets into the cell, makes the protein, the spike protein that we then develop immunity to. The adenovirus is kind of one step in back of that. It's that genetic blueprint in a virus that cannot replicate. It gets into the cell, that DNA gets into the nucleus of the cell in this case, gets converted to mRNA, and then acts just the same way as an mRNA vaccine. So it's an additional step. The issue is that the AstraZeneca vaccine did run into some manufacturing problem, and in a way, serendipitously, because they discovered that 2 full doses led to about 70% efficacy, whereas a half dose as the first dose and a full dose as the second dose led to 90% efficacy. So that indeed is a mistake in our favor, so to speak. And I think they'll need to run some more studies on that. Only 3,000 people got that half dose followed by a full dose. They'll do some more studies, and then we'll start to see that become available very likely by EUA in that first quarter of 2021.
Greg, I feel like every time I ask you how a vaccine works, it gets more complicated and my eyes start to glaze over as it goes over my head. But I know that the Pfizer vaccine and Moderna work very similarly. They're a relatively newer technology. Is there a comparison to the AstraZeneca vaccine as far as vaccines that we already commonly use? Or is that a new technology as well?
Yeah, it's also a newer technology. Now, we actually have a viral vectored vaccine licensed in the US, not really used much here. It's an Ebola vaccine, but in this case, they use a VSV virus rather than an adenovirus to carry that genetic blueprint into the cell. But I think the way we should think about it is mRNA and adenovirus or any viral vectored vaccine operate very similarly. At the most basic level, they're simply delivering the genetic blueprint. Think of it as the engine for a car. The car's already there. It just needs the engine to get going. And that blueprint, that genetic code is what an mRNA or an adenovirus vectored vaccine brings to the cell. And then it matches that car, puts that engine in, produces the spike protein, and we develop immunity. And it's extremely efficacious. I mean, again, I can't describe to you how surprised I was that we were at 95% efficacy. This is outstanding. I mean, it is, as I've described it, a grand slam.
So Greg, and because I've had this question repeated by colleagues and by listeners as well, there is no concern that that genetic material that we're supplying to a vaccine could be incorporated into our own genetic material and change us permanently in any way.
Yeah. So, I like to be very, very honest and transparent about this. With the mRNA vaccines, no concern at all. It does not have the attributes that would even allow it to get into the nucleus of a cell where our chromosomes are. The adenovirus and viral vectored vaccines do have the DNA that they carry get into the nucleus of the cell so that it can make mRNA. So is there a theoretical risk? You have to say yes. What is the observed risk? It's never been observed to integrate into mammalian chromosomes. So the observed risk is in fact zero. But you can never say never. It's just that it's never been seen. So we're pretty confident.
Another thing that I had heard, and knowing that there's kind of we're all waiting for vaccine at this point, is that the Pfizer vaccine has had some extra doses in the vials. I think that it was that they're intended for 5 doses, but some of the pharmacies felt that they could get 6 doses out of them. What's the situation with that, and are those usable doses?
Yeah, absolutely they are. It's actually not a surprise to us. I guess it was a surprise to the media. So the bottles, and it's like anything, to be on the safe side, you say that there are 5 doses in there. But remember that the dose is 0.3 ml, and you're putting 1.8 ml of sterile saline in to reconstitute the vaccine. So you can actually get upwards of 7 doses in it. The key thing is that you just draw out 0.3. You need to get the full 0.3 dose, but otherwise, yeah, I mean, it effectively extends the number of doses that we can give. And I think that probably just didn't come through very clearly to a lot of people.
So after I received the first dose, or our listeners received the first dose of the vaccine, do I then have immunity against COVID-19 or does it require that I get that booster shot again later to really have the immunity?
As far as we know right now, you definitely need the second dose. Nobody has studied a single dose and not gotten the second dose. But here's what we know. In the Pfizer and Moderna study, people that got the first dose, about 7 days later, between 50 and 80% of them had what we think will be a protective immune response. But 50 or 80, anywhere in there, is not enough compared to 95. And that's what that second dose does. It takes you from here and boosts you up to there. So we definitely want people to get 2 doses. The other thing that is that not only do more and more people get protected, but your antibody level goes up. And remember that the higher your antibody when you finish, the longer it would take for that antibody level to start decreasing. So it is in fact important that you get 2 doses.
So how long after the second dose can we consider ourselves immune? How long does it take?
Well, it's about 95% efficacious. So there'll still be 5% or so of people who may not respond to the vaccine. When you look across an entire population, that's still hundreds of thousands. So we want to be careful until we get 80+% of the population immunized. But what we're saying is that in that 7 to 14 days after the second dose, you're going to have the level of protection that you can get out of that vaccine.
So just after we're celebrating that there are vaccines available, there are all these news stories about the virus mutating and arising in different, in a mutated form in different areas in Europe, et cetera. Can you tell us about that? And are there concerns about this for the United States? Will the vaccines that we have work for this?
Yeah, so let's kind of break this one down because it is important. The new variant is called VUI 2020-1201. VUI stands for Variant Under Investigation, 2020 the year, 12 the month, and it's the first variant observed in December. Now, this particular variant is of concern for several reasons. It has 17 mutations, and one of those changes an amino acid in the receptor binding domain, the part that antibody would and spike protein bind to. So it's actually an important mutation. In fact, the modeling studies, which are different than laboratory studies, but the modeling studies suggest, based on what we're seeing in the UK and in continental Europe, is that this may be as much as 70% more transmissible. So the absolute worst thing that could happen is widespread travel over the Christmas holidays and this variant spread and actually become a variant that spreads more easily than the strain that we currently have. The question you've asked is the really important one. Does that variant have any functional significance? Could it evade monoclonal antibodies or antiviral treatment or vaccine-induced immunity? We don't think so at this point, but that is a possibility that's being very closely looked at. But we had this variant detected in October in the UK. It's now in Denmark, the Netherlands, Australia, Belgium, Italy, and it will come to the US. So, it's again one of those things that, if I could wave a wand, I would say no travel and don't let this virus continue to be transferred from one human after another because it will just keep accumulating mutations. And by chance alone, one day, one of these mutations is going to cause a much worse disease or evade the vaccine immunity that we have. Again, we haven't seen that yet, but that is a biologic possibility.
And I certainly think that in the UK, they have taken that to heart and have really increased the restrictions on travel over the Christmas and New Year holidays, as I understand it.
Absolutely. I talked with one of my colleagues over there by email, and they were working all weekend on this, starting the laboratory tests to say what's really going to happen with this variant. As you say, a number of countries now have locked down any flights from the UK coming into their countries because of fear of widespread transmission of this variant.
In some situations, travel may be essential for certain individuals, and I know that the CDC has put out some guidance around recommendations for being tested if one must travel.
Yeah.
Maybe you could clarify those with us. I also saw that there was a home test approved,
Yeah.
and I'm wondering, is that accurate?
Yeah, that's a good question, Helena. And I don't actually have a lot of details on the new home test that was approved. I'm wary because a lot of those tests have undergone, EUA approval, only to find out in the testing realm that they're not as sensitive or specific as we would like, leading to false positives and false negatives. So I don't know if this new test will be found to perform well as it gets widely used. But the recommendation is that people not travel. If for some reason they have to travel, the best thing to do would be to start a quarantine 10 days before you're going to travel, get tested the 3 to 5 days before you travel. Once you travel, wherever you are, 3 to 5 days later, get tested again. The problem is this, and I have fielded, I don't know, I can't count anymore, hundreds and hundreds and hundreds of phone calls and emails. No one thinks that they're the one that's infected, particularly when they don't have symptoms. I dealt with a family this weekend where they had one breach of letting a family member in that normally isn't in their home for a meal, and 6 of them got infected. 1 ended up in the hospital. That's how easily this happens. And as I say, nobody thinks they're the one carrying the virus. But the fact is, when you get up to, what do we have? Over 18 million cases in the US, 300,000 new cases a day. Now we're at a point where about 1 in 1,000 Americans have died of COVID. And the best estimate is that by the time this is done, 1 out of every 700 Americans will have died of COVID. So, it is in all of our interests to not allow this virus to spread and get the vaccines out so we can be over with this as soon as possible.
That's a really sobering reminder, Greg, and very poignant to hear personal examples from people who've had difficulty in their families. Thank you for sharing that.
Yeah.
I have a question for you about vaccine allocation again. So my curiosity is that we have these phases of individuals who are supposed to be vaccinated according to essential workers, healthcare workers, et cetera. How do you identify those people? Are they being registered somewhere? Does the government have that information? Or how does one register as an essential worker to get a vaccine, for instance?
Yeah, this is the the actual practical operational difficulty of what sounds like a good plan, because there is no registry of essential workers. There is no registry of who are the frontline healthcare workers, who are more in the background. So the way the plan was devised is that whatever number of doses of vaccine we had would be allocated to each state, and within that state, in their state public health departments, for example, at the state level, they would make the decision about how to allocate doses. Now, the problem is that they're not getting as many doses from Pfizer as they thought. We've gone from 40 million to 20 million doses.
Why is that, Greg?
Well, the idea was, and it sounds almost too simplistic, but Pfizer was saying that we will have 40 million doses. That's different than we currently have 40 million. What we currently have is 20 million. And by the end of the month, 40 million doses. And I think people, again, misinterpreted that there was some kind of communication snafu in there. So what will then happen at the state level is each state will make allocation decisions. usually going, because of the freezer requirements, to the larger medical centers, giving them the vaccine and giving them the steps of who's in the first wave, second wave, third wave, et cetera, all the way till this weekend. CDC defined 7 different waves of priorities for vaccine. As you're pointing out, at Mayo Clinic, we have no idea who works in an essential job, who's a police officer. Well, you can figure that one out pretty quickly. But grocery clerks, repair,
daycare workers,
daycare
teachers.
Workers, repair, it's very hard to do. So I think there is an aspect of that will be honor-based, right? We hope people would be truthful, because we want the people who are most at risk, because they're helping other people and sustaining our society, or have medical problems that place them at high risk. They should be first in line. That's how I feel about it. I couldn't live with my conscience. I should not be one of the very first. Soon after that, yes, because I teach in the hospital, et cetera, but I'm not working directly in the COVID unit. I'm not going to try to step ahead of those people. I couldn't live with myself if I did that. So
an orderly process to it all.
Yes, indeed.
It's exciting that it's happening, though, Greg.
Oh, yes. This is great news. I mean, this is an unparalleled human achievement. It's unbelievable that in 9 or 10 months from genetic identification of the organism, we have what appear to be, by every measure we know to use, safe and effective vaccines. There's more to do. We've only done this for 9 or 10 months. But this is an unbelievable human achievement. We are literally living through a golden age of science, which makes it all the harder to realize that there are people who reject science. But that doesn't dissuade me. This is a golden age, and we are reaping the benefit.
And it is wonderful to have hope for the holidays.
Indeed.
What a wonderful Christmas and holiday gift for all of us.
Indeed.
Well, thank you for being here, Greg.
My pleasure.
Thanks to each of you for being with us today. We visited with Dr. Greg Poland from the Mayo Clinic, who's an expert in vaccines, viruses, and infectious disease. And we certainly wish all of you wonderful holidays. I hope that you learned something today. I know that I did. And we hope that you go into the holiday season with hope in your hearts and looking forward to 2021. Have a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well.